Good afternoon and welcome. Today's hearing is the first of two that will occur over the next month to examine the VA's recent proposals to modernize the VA healthcare system to better serve veterans in Kansas, Connecticut, Arkansas, Washington State, and everywhere else veterans call home. Today, specifically, we will examine the plan that the VA announced last month to restructure the Veterans Health Administration. The Restructure for Impact and Sustainability Effort, or RISE, represents the most significant reorganization of the VA's healthcare system since the 1990s. Once fully implemented over the next 2 years, RISE is designed to change how the VA manages and oversees the delivery of healthcare to veterans across the country. Our goal today is straightforward but serious, to examine how the VA arrived at this plan, how the VA will put this plan into place, and most importantly, how it will improve the quality, reliability, and accessibility of the VA healthcare system and lead to better experiences and outcomes for veterans who rely on it and for the VA staff who work within it. The department describes RISE as an effort to reduce bureaucracy and red tape, empower local leaders, standardize operations, strengthen accountability, better align VA resources and needs of VA patients and staff. These are important goals, and I commend the Secretary and his team for prioritizing them. Countless findings from this committee, the VA's Office of Inspector General, the Government Accountability Office, and others have detailed serious deficiencies within the VA healthcare system that RISE is intended to address. A decade ago, for example, a Government Accountability Office noted that, quote, recent internal and external reviews of Veterans Health Administration's operations have identified deficiencies in its organizational structure and recommended changes that would require significant restructuring to address, including eliminating and consolidating program offices and reducing VHA central office staff. That's from the Government Accountability Office. And in testimony last Congress, the Inspector General's office noted that the VA's current VISN structure, quote, did not ensure accountability and lacked clear, defined roles and standardized responsibilities, which could lead to deficient engagement with facility leaders and inconsistent oversight. At the same time, while reorganization can sound like a good thing, and often it can be, reorganization carries risks. I look forward for this committee to get a better understanding today of how the VA will mitigate those risks, measure success, and protect continuity of care during this transition. I also look forward to hearing how the VA will engage with veteran patients and their families, VA healthcare workers, community providers, veteran service organizations, and Congress about the changes moving forward. I've served on the VA committee with, my remarks say 8, but I'm told now it's 11 secretaries of Veterans Affairs. They all made promises to improve the bureaucracy, backlogs, implementation of VA care, and while they have made good faith efforts to do so, we continue to look for long-lasting, successful changes and improvements at the Department of Veterans Affairs. I look forward to the Secretary Collins making the case for why he thinks his plan will finally make lasting changes. I thank Secretary Collins and the other VA leaders for joining us today to discuss their important work and how we can all work together to make the Veterans Health Administration more worthy of the men and women it serves. With that, I yield to the ranking member, Senator Blumenthal, for his opening remarks.
Thanks, Mr. Chairman. Welcome to Secretary Collins, to your team, and to all who are here today and perhaps listening by live stream. I want to begin by taking a moment to honor the memory of Alex Preddy. As I think all of you know, Alex was an intensive care nurse at the Minneapolis VA Medical Center, one of the most demanding jobs at the VA healthcare system, and he was one of the most dedicated of the staff who served our nation's heroes. By all indications, he dedicated his life to caring for others, particularly veterans. He wanted to make a difference, and he did, as evidenced by the countless coworkers, veterans, and families who have come forward with stories about his compassion and his positive impact on their lives. Alex loved his job. He loved his family. He loved his country. That's why he was on the streets of Minneapolis last Saturday morning. He was protesting and documenting what he saw, and many of us see, as unlawful and unnecessary assault on our communities. And after coming to the aid of someone who was assaulted, a woman who was struck by masked federal agents, he was pepper sprayed, tackled to the ground, beaten, and shot in the back multiple times while lying unarmed and posing no threat. As we come together today, I hope the memory of Alex Preddy will inspire us to do better for our veterans, for our country, and their families. Mr. Secretary, I appreciate your being here. I regard your appearance as overdue, if I may say so, with all due respect. I respect that there are ways to reduce our bureaucracy at VHA to improve the quality and timeliness of care for veterans, and I think you'll find support on both sides of the aisle for that goal. I have concerns about the potentially negative impacts of the reorganization on frontline employees and how restructuring the nation's largest healthcare system will be impossible without dedicated, experienced staff in human resources, IT, finance, resource management, operations, and clinical leadership. I want to know what the implications and the impact for those resources will be as a result of this reorganization. And I welcome this conversation. I really welcome your being here. And I will say, again, with all due respect, there has been too little conversation and too little responsiveness on the part of the VA to questions that have been asked on both sides of the aisle and requests for information that we have made. I hope we're turning over a leaf and beginning a new chapter. As you may know, I prepared a report on this first year with facts and figures about the results of cuts in workforce, cancellation of contracts, reduction in force, a lot of it the remnants of the DOGE deluge in its impact on the VA and so many other functions of government. And if anyone in the VA disagrees with the findings and conclusions of that report, I hope we will be given facts and information. That's the coin of the realm in the Congress. That's the way we do our job. And you may recall, no doubt you do, that past secretaries of the VA on both sides of the aisle have not only provided that kind of information, but hosted substantive conversations. For example, with the Four Corners leadership on a regular basis. I participated in them with Secretary Shulkin and Wilkie under the Trump administration, as well as McDonough in the Biden administration. Nearly all of your predecessors have welcomed accountability and made concerted efforts to build constructive relationship with Congress, an approach that leads to better outcome for veterans. And I hope that in turning over this leaf and beginning a new chapter, we can move forward to provide for more responsiveness and more facts forthcoming to our veterans, to the veteran service organizations that so ably advocate for our veterans, and to serve the common goals that we have and that bring us here today. Thank you, Mr. Chairman.
Senator Blumenthal, thank you. As I mentioned in my opening, we're joined this afternoon by Secretary Collins and his team. Accompanying him are the Honorable John Bartleman, Undersecretary for Health, Mr. Mark Egelbaum, Assistant Secretary for Human Resources and Administration, and Gregory Goins, the Acting Chief Operating Officer for the Veterans Health Administration. I appreciate you all being here. I'm glad that this hearing is taking place, and I'm glad that all members will have the opportunity to have a conversation and a discussion with you and your team, Mr. Secretary. And you are now recognized for 5 minutes, or perhaps as long as you take.
Thank you, Mr. Chairman, and Mr. Ranking Member, and all the members who are here. And Mr. Ranking Member, it's good to be with you again. Yes, there's a lot of conversation I'm looking forward to having today and continuing that conversation. I do appreciate your tone, and I appreciate how my tone hopefully will be matching that as well as we go forward to get real answers for the solutions that we've been looking for a long time. So I do appreciate that, and with the other members of the committee as well, that we can do that. But before I begin, I want to express my deepest sympathies to the family and colleagues of Minneapolis VA Medical Center nurse Alex Preddy. As you know, the death is currently under investigation. VA is not involved in that investigation. Neither I nor my fellow panelists are really able to give additional details at this time. And in this troubling time, I just want to make that very clear to this committee, and also in the words that you said, Mr. Ranking Member, as well, echoing the this going through our medical center, and we're going to continue to be and lift the family up in our prayers with that. But the reason I'm here today is also what you and the chairman have talked about, and that is addressing a lot of things that have been coming up over the years on discussion on how we can reorganize VHA to do what it's supposed to do and take care of veterans. Put the veteran first. There's been a lot of misleading and inaccurate descriptions of how we're doing this effort. But first off, let me just state this is not a reduction in force. This is not an effort to diminish direct care for veterans. This is a reorganization that will eliminate the glut of VA administrative overhead and push more resources directly into the field. The chairman made a statement just a minute ago that is so true that I found that we didn't act like. And I didn't even have this knowledge when I first got onto the job until I actually got in and started visiting over 30 states and looking at over 70 facilities, that we're the largest healthcare provider in the country, but yet we didn't act like it. We didn't act like the largest healthcare provider in the world in many ways because we were trapped internally into our own policies, procedures, things that have been added on, none which added up to taking care of veterans, but ended up taking care of the VA itself. And I think that's really where we had to start, is asking them. Many of the things that we're going to talk about today came from OIG reports, GAO reports. It came from Congress. Many of you, we went back over testimony over the years and looked at what Congress has said about how is the organization balanced, how is it made. Chairman Moran's own comments, also the comments on both sides of the aisle on how we can make it better for the veteran itself. But we've also listened to VSOs, taking into their account all throughout the year and looking at them and saying, how are you on the front line with your own membership seeing what is happening in our hospitals? This is where you get the information. It's not many times in seeing a cold report. It's actually being in the field and talking to the executive directors of these hospitals to say, what do you actually need, and listening to members. Senator Hassan, as we had when we went and visited together, you see a lot of good stuff when you're there, and that filter is what I've tried to break down. And as you heard me say as I was up there, when I talk to executive directors, I say, what can you do that you're not doing now? What is stupid, and I use that term from my own term, that you do that nobody else does? And it's amazing how that broke the walls down, Ranking Member. That's amazing how all of a sudden, and Mr. Chairman, they began to talk about things that needed to be changed. Those are where we come from as we move forward here and looking at where we are. We also looked outside. We looked at other organizations outside the VA that are large in scope and large in healthcare and say, how do you actually manage this? How do you do the large programs that you have, that all of your districts have, all your states have in your public and private healthcare? Now, what we found was the VHA needs reorganization and reform, and that's exactly what we're doing. Here are the goals: improve healthcare quality for veterans, empower local hospital directors, eliminate duplicative layers of bureaucracy, ensure consistent application of VA policies across all department medical facilities. So this is the thing that we've got to get to, true lines of authority that allow our executive directors and allow our hospitals and clinics to do what they're supposed to be doing, is take care of veterans. We don't have that. I'm going to use an example that you can see in my remarks that we sent up, is that no one many times knew what to do when they had a question, because we had policy scattered all over the VACO. We had our central office that had everybody sort of taking apart as what I call the camel committee. It was supposed to be a thoroughbred, but ended up we got a camel out of it because everybody had a part and nobody talked to each other. And at the end of the day, the hospitals and clinics were left to figure it out on their own. Now, there's a lot of scary stories out there about how this is bad or could be bad. What I want to do today is act on more than 2 decades of discussion in this committee and also in the House on how we can make this better. We've done some really good things this year. We've reduced, Mr. Chairman, you talked about backlog. We've reduced it over 60% from 260,000 down to 100. By the way, as is discussed, the appeals on that are still in line with the increase in actual backlog being taken down to actual appeals is within line of what you would expect with a normal increase in decisions made. We've eliminated the backlog for veterans' families for health care. We've opened 25 new health care facilities, and we're permanently housing 52,000 homeless veterans. I look forward to a great discussion today. I believe this is generational change. I believe this is something that both sides can agree on and find ways to move forward, and I look forward to providing any information. As I said earlier, though, I do have the folks with me today that I want to emphasize with our Undersecretary of Health, John Bartram, with our Mark Engelbaum, with our HR, and also our Chief Operating Officer right now, Greg Goins, who has been with the department for 13 years. He overlaps everything that has been done, and he can tell from past history how this was tried to be played out in its beginning. So with this, we got a lot of help. I brought a lot of help because I wanted you to have all the information that you need. And with that, Mr. Chairman, I'll yield back.
Mr. Secretary, thank you. We'll now have a round of questions, and I'll begin those questions. First of all, one of the experiences I've had over a long period of time is I have occasionally been able to get the Department of Veterans Affairs' attention on a particular veteran and his or her problem that needs to be addressed. I've also, from time to time, been able to encourage and been assured by the VA that certain policy changes that made no sense to me and to others were being corrected. In both instances, I want to indicate that the end result is not the result I was totally looking for. And so fixing a veteran's problem never meant it fixed anybody else's problem who may have had the same circumstances. So that's one. And then policy changes, I discovered that the VA, the Secretary, and others would tell me that, no, we've changed that policy, but only to go home to find out that no one in the VISN, no one in the hospital knew about the change in the policy. Will your reorganization address and solve those kind of problems?
Mr. Chairman, I couldn't have done it better in 1 minute to describe why we're doing what we're doing. You've just described it from every member on this panel and every member that's not on this panel, is finding a solution to the individual problem that should solve a policy problem but does not. And that's why we actually have the problem that developed in this over time. And I'm not going to go back to any prior secretary or even prior administration, both Democrat or Republican. I think there were good intentions all along. But when you get an internal growth and you have a department so large that they can't basically move because of internal frameworks, this is where we get the problems. I would like to, Mr. Chairman, I want to address Greg Goins, who's been a member almost 14 years in the VA, working at a VISN level, working at a hospital level. Greg can talk about how what you just talked about was so difficult when you had policy taken in one place and never applied in the hospital level.
Thank you.
Yeah, thank you, Mr. Secretary. So in my time as a medical center director and also a VISN director, now in this role as an operations officer for VHA, it's very clear that there's a lot of silos within our organization, and that ultimately creates a lot of disconnect, both between what's actually drafted in policy and also the guidance that's being given from those subject matter experts. And so as a result, it's very common in current state of affairs for a frontline worker to be engaged with a veteran and have a challenge with something that might be written in policy or something that might have been given in guidance. And when they try to get clarity on that, they might get 5 or 6 different answers depending on who they go to, between the program offices, the VISNs, even their medical center director. This new organizational structure creates a new element that does not exist currently, a medical operations center. That medical operations center's focus is to take policy from the DC level and interpret it so that there is one application to the way in which that should be implemented. Nothing pains me more than when I'm serving a fellow veteran and I get a call, maybe it's from you or somebody on your staff or maybe somebody in VACO, and I need to address the challenge that individual veteran has, but the pain that I have knowing that this could happen to someone else. This organizational structure change, this management redesign is going to allow us to create continuity from the top all the way to the front line and allow us to flag those type of events proactively so that the communication to the field is consistent so that we fix those things and escalate them real time.
Thank you for that answer. One of the aspects of reorganization that you are addressing are the VISNs. It took me a long time to learn that the VISN was not really supervising the hospitals with direction or capability, responsibility for doing so. I always, in my early days, assumed that the VISN was the overall arching leadership when it came to the hospitals within that VISN. Your RISE Act indicates that we will reduce the number of VISNs from 18 to 5. VISNs, just the reduction in and of themselves, is insufficient unless the VISNs have purpose and meaning, relevance. What problem is the consolidation of VISNs under RISE intended to solve? How will specific roles and responsibilities of the VISNs change once RISE is implemented? And what benchmarks will the VA and this committee be able to use to evaluate whether the new VISN system is resulting in better outcomes?
Mr. Chairman, just real quickly on that, that was part of the problem. We had a VISN structure that was not, in fact, there's an article today out of Georgia, my home state, of Dublin VA Center, in which it showed the inadequacy of the VISN system in seeing a problem but not acting on a problem, and that was a policy decision and the way this happens. John Bartram is our new Undersecretary of Health who will be actually over this. What we've actually done is we've taken the 5 divisions, then also added HSAs who then can actually do more market-centered for your rural hospitals, your urban hospitals. They're more directed into how they can actually help those hospitals and give them better direction, while the VISN level is now concerned with actual implementation and management of that. And I want the Undersecretary to discuss
Secretary
that.
Bartum?
Yeah, sir, thank you for this opportunity. I really look forward to implementing this change across the department. But the scope of the VISN directors, as you're talking about, is too broad. And we've got to focus that down so that they're doing the executive level work and the strategy of looking up. And with the health service areas, those HSAs, they're looking down at more narrow markets. And they're still working for the VISN director. But now they're able to focus on what is going on and help support that hospital director. So that support directly down to the facilities is providing that support so that we can assist the hospital director as opposed to add bureaucracy to the process. I realize I'm over time. I didn't want to go any longer unless you want me to, but Greg Goins can give you a little bit more in depth as a former VISN director of the perils that he had to face in that role.
Mr. Goins, I was reluctant to ask my question in the manner which I did because I didn't want you to seem to yourself irrelevant.
No, sir, I did not feel that way at all. In fact, I think in the last several years of being in that role, I celebrate the opportunity to correct this and to improve it for our veterans and our employees in particular. As a VISN director, a day in the life of, very much of your time is spent trying to compete with multiple responsibilities. Okay, that's fine. If you're an executive, you expect that. The issue is with the scope of responsibility being governance and oversight and appropriations, et cetera, every time that you spend on that, every day of the week you spend on that, it's a day of the week you cannot spend in community stakeholder engagements, medical center engagement, medical leadership engagement, veterans and their families engagements, and also engagements with our local partners like yourselves, our legislative partners. So what this redesign does actually is it de-scopes the role of the VISN director to focus on the oversight and governance aspects of that role in one place. That's those 5 VISN directors. Then we have these new elements within each VISN called health service areas. And those health service area directors, their sole responsibility is to focus on the day-to-day interactions with the medical centers and their leadership teams, along with all those community stakeholders I mentioned. It gives them an ability to understand real-time the challenges that are happening in the facility and also work real-time with those facility directors and their teams to resolve those challenges without having to go up and down the chain of command.
And sir, if I might add, the other aspect of this that sometimes gets left out is currently the VISN directors don't report up to the undersecretary. This streamlines that. So when people talk about bureaucracy, this streamlines the bureaucracy so that the VISN directors will report directly to me. And so that allows me to have better access to what is going on in the field and where there are issues, just like the mock director as well. So instead of having this bifurcated system where we go through all of these different channels. The Undersecretary for Health will have the 5 visiting directors and the mock director, and then his 2 deputies, the principal and the deputy. So it'll be a much tighter team to be able to implement future changes.
You're all for your answers. Senator Blumenthal.
5-minute round.
Yeah, well, Senator Blumenthal asked the question of the 5-minute rounds. They are from now on.
I've been there, Senator.
Thanks, Mr. Chairman. Mr. Secretary, as you may recall, Congress provided an additional $6 billion, with a B, $6 billion in fiscal year 2025 for the VA to meet the higher than expected costs and demand for VA health care. That funding was supposed to be spent on additional providers, community care utilization, rising costs for prescriptions, and prosthetic devices. My understanding is that almost all of that $6 billion was used to cover the cost of the cuts in staff, deferred resignation program, and voluntary early retirement that included paying out vacation time to employees who were paid to stay home and not work. Can you provide this committee with a full accounting of the $6 billion, which I think is very important because apparently it was used to push out essential VA healthcare providers rather than sustaining VA medical operation as we intended? I know you may not be able to do it right here, but I would like an accounting of that $6 billion, hopefully within the next week.
Mr. Ranking Member, sure that we'll look at it and get through the numbers of that. Richard Topping, my OM, is here, and we'll get you that information. But I will rest assured, one of the part that I would just take a little bit of umbrage is nothing was used to push anyone out in that regard. These are all
Well, rather than
voluntary
going
issues, but I will
into the
get that.
rhetoric, I
Yeah.
want the numbers.
You get the numbers.
And talking about numbers, my understanding is that more than 40,000 employees have left the VA since last January. Can you provide this committee with a detailed, updated workforce compilation of data, the number of staff who've left the VA since January 2025, broken down by facility and position, and the list of positions and vacancies each facility plans to cut based on the caps that you set late last year?
Mr. Ranking Member, number one, there's no, we'll deal with the caps as you find it's best. That's why Mark Engelbaum is here from Human Resources, who'll be happy to answer that question.
Well,
We will get you
we'll
get you information. That's not a problem. I want to make sure I get you from me. Yes, we'll get you the information. But I think it's good not only for this public to hear, but also for you to hear what it is actually the numbers from HR on this.
You have numbers, sir?
Yes, Senator, and we'll provide you the numbers and position
Thank
level
you.
detail. For clarification, we reduced about 30,000 personnel, not 40,000. The 40,000 is the total losses, sir. We actually
The total losses, I understand that you've
30,000.
hired people since then, but not necessarily for the same positions. That's why I want the breakdown. We've asked for it repeatedly, sir. We have not received it. I'm asking again in this forum. I shouldn't have to do so, but I welcome your willingness to provide this information.
Happy
Let me
to do
ask
that,
you next, because my time is limited to 5 minutes, the department's annual veteran suicide data report is overdue, even though it has reportedly been complete since September. Can you confirm your legislative affairs team has issued a non-concur to the report when it was provided by the VA Office of Mental Health and Suicide Prevention?
Mr. Ranking Member, I have no knowledge of a non-concur. I know that the report was being finalized in the fall and then the
Well, it's
shutdown.
overdue. Will you provide
Yeah,
it?
we're providing, and it hopefully will be out very soon.
As you no doubt agree,
Yep.
veteran suicide is a major issue tragically and unfortunately continuing as a major issue. Do you
There's
agree?
nobody in this room more apparent than that, and nobody working harder to
So
make
I
sure that
think
that
you
happens.
owe it to the Congress and to our veterans that that report is issued.
It will.
Let me just say, on the issue of mental health, wait times have increased. Can you provide to this committee the wait times for mental health care in facilities across the country? I'm asking for the details in regard to those whatever number of facilities there are that provide mental health care.
I'd be happy to. In fact, I can give you some numbers now, but also something that I could not give you when I first appeared for my confirmation hearing was a dashboard that actually looked at metrics such as that I could see every facility on a real-time basis.
Well,
One of the
then you
things-
can see that the wait times have increased,
and well,
sometimes
actually-
to 50, 60, or 70 days.
Actually, that's not true. And as of January 21st, the national average for mental health care for new patients is 18.8 days. The national average for established patients is 5.8 days. And if you would need an emergency care or you're in need of or you're in a crisis situation, you have immediate care. That is the actual numbers.
Well, that is contrary to the information we've been provided, and I'd like facility by facility data on the wait time for mental health care. My information is 1/3 of the states have an average wait time exceeding 40 days. Only 3 states represented on this committee have new patient primary care wait times below the threshold for community care, and the wait time for mental health care at many VA facilities is 50, 60, or 70 days. But I welcome the information that you are going to provide. Mr. Chairman, I apologize, I'm over time.
I didn't notice, but we'll now reinforce the 5-minute rule with Senator Bozeman.
Thank you, Mr. Chairman and Ranking Member Blumenthal. Mr. Secretary, we've all heard about the bureaucracy and inefficiencies in the system, and that's certainly not any secret. Throughout your modernization, veterans' abilities to receive care must remain unaffected. What protections are you implementing to ensure continuity of care throughout the VA RISE process?
I think that's been the whole focus, Senator, is to what we're doing is designed to not interfere except in that care, but actually make it better. And we've seen this as we go along. I can think of ways over this past year using best medical interest where we've actually cut out a layer of the bureaucracy, making sure that people can get to community care quicker. We've actually, aligned our women's health into where now they do not have to go back through their primary care doctor to get to their normal women's health needs of gynecological obstetric care. They can go straight there. So this is the kind of things that we're working on. I would be happy to let our undersecretary deal with that just a little bit more.
Yeah, Senator, I think you've seen the organizational chart that we've shared with the staff. And as you look at that, you'll see the bottom part of the chart, which is the medical centers. We're not making any organizational change structure in the middle part, or in the bottom part. All of the changes are at the policy and at the VISN middle part level. We're trying to get the structure aligned. We're working to get the structure aligned so that the information flow to the facilities and to support the facilities is at the facility level. And we have policy offices right now that at the policy level do policy implementation and execution. And what we need to do is to get them out of the execution business and let the facilities do the execution. And we just provide them the standardization and the right and left boundaries in order to execute. So that's how we're mitigating the risk relative to the facilities, because we're not making significant changes at the facility down level. Everything is up, and how do we add additional support to the facilities? And Greg, I'll ask you if you have anything.
Yeah, if I can add one more thing, Senator. My background in process improvement has always told me that the best people that understand the way to improve things are the people actually doing the work. So the number one priority through this reorganization is to make sure that direct care is not impacted for our veterans and their families. The number one way to make sure that doesn't happen is to take input perpetually from the people actually doing the work, frontline clinicians, in addition to our frontline executive leaders. They have been engaged on this change from the beginning. And moving forward, nothing will happen with this reorg without their input and without understanding how any changes that we are projecting to make will ultimately impact the reality for the veterans and their families in the facilities. They will be involved every step of the way until we get to the finish line.
Very good.
And sir, if I could add on to that, the development of this plan was from VISN leaders. The VISN leaders are the ones who worked to develop this plan. This was based on the people who running our organization from the ground up, and they got input as they developed it over a 9-month process. It was an iterative process, and they engaged with outside expertise as well as our own internal consultants that we have within VHA.
Very good. With Senator Murray's help and Senator Collins, them leading us forward, we're about to wrap up the appropriation cycle, and which is really remarkable. Almost immediately, we'll begin again. Do you currently have the necessary funding authorities to execute VA RISE, or is it going to need some additional help in that regard?
Senator, yes, we do. And we're, looking ahead for our fiscal 26 budget. We appreciate the numbers that have been given to us. We appreciate Senator Murray, you, and others in the Four Corners. We've had these discussions. We had some discussions early on concerning some transfer issues, which I think we worked out. And I do appreciate the Appropriations Committee's concern there, and it was taken to heart on our concern. We are currently allocated at fiscal year 26 community care appropriations at $50,174,000,000. We are budgeting to that, and we do believe that we'll be able to make that. And also, we appreciate the input that we got from the Four Corners on other information there as well.
Good. Very quickly, I just want to mention that I had the opportunity to go to Fayetteville, Arkansas the other day at Patriot Park, and we have a lot of challenges that we're working through, but we always have to remember there's a lot of good things going on in regard to veterans and people just stepping up. This is a great public-private partnership that's come together that is going to offer very affordable housing for our veterans and should be completed in the next few months. And hopefully we'll get you out there, Mr. Secretary, and maybe some of the rest of you to really see a project that we can all be very, very proud of. Thank you.
Look forward to it.
Thank you.
Senator Murray.
Thank you, Mr. Chairman. Before I begin my questions, people across America are really reeling from the horrifying murder of Alex Preddy by federal agents. And as we all know, Alex Preddy was an ICU nurse at the Minneapolis VA Medical Center. He is remembered by colleagues and friends as a calm presence amid the chaos of the hospital, someone who cared deeply for the veterans he served. He was remembered as a mentor, a caretaker, and someone who wanted to make a difference in the world. The father of one veteran Mr. Preddy cared for until the end described him as the sweetest person you can imagine. Alex Preddy spent his last minutes trying to help a woman. She was a bystander who was being assaulted by federal agents. He was killed by those federal agents moments later. Immediately after he was killed, the Trump administration began spreading sickening lies about him. They lied about who he was, what he was holding, what he was doing in the moments before his death. Trump and the miserable folks at the DHS showed right away they didn't care about getting the facts, any facts. They told Americans not to believe what we all saw and heard with our own eyes and ears. We all saw an American shot and killed by federal agents in broad daylight. Mr. Secretary, your initial response to a VA nurse being killed by federal agents was to blame it on Minnesota officials. You didn't say a word about who Alex Preddy was or the incredible work that he did for veterans. You mentioned him today, but still didn't refer to that. That is certainly a choice. Words cannot describe how outraged I am and how outraged we all should be at the killing of Alex Preddy, who simply did not have to die, and at this administration's rush to spread lies about American citizens whose only crime was peacefully exercising their First Amendment rights. Joining ICE or Border Patrol doesn't give you a license to murder. So I want to reiterate to all of you that there must be an independent investigation and real accountability here. This can't continue, and I hope that we agree on that basic point, and Republicans join us to work with us to make that happen. But, Mr. Secretary, I wanted to ask you today, it is my understanding that Minneapolis VA employees have not been granted personal leave to mourn their colleague because they're subject to mandatory overtime due to staffing shortages. Are you allowing any of the employees there to get personal help, to take any time off, or to offer them your support as they go through a very trying time of losing a very close colleague?
Thank you, Senator. Yes, we are providing all that we can through the Minneapolis VA to those workers, and I will have Greg Goins, who's been in contact with them, discuss that.
Not only did we have conversations the day that this actually occurred, it also has happened every day since it's occurred. All the resources that we offer our federal employees when times like this occur, these tragedies occur, they're offered employee assistance programs, they're offered whole health employee assistance programs, they're also offered things through community partners if necessary. If anybody comes forward to want to take leave because of a coworker, a close coworker, we always have empathy in allowing them to do so. In fact, the very first contact that was made in that medical center was with ICU coworkers. And if I could just add, and I apologize, they just had a memorial service for Alex Preddy yesterday at noon where over 300 employees attended and were able to memorialize and remember him.
Well, Mr. Secretary, I think it's important your words to those employees personally be taken care of. So let me move on. I want to move to a really important discussion as well, because in late December, not long ago, the Trump administration quietly implemented a near total abortion ban at the VA. VA's final rule prevents the more than 460,000 women veterans of reproductive age, over half of whom live in states with abortion bans, from receiving abortion care at the VA now. VA providers are not even allowed to discuss abortion as an option with veteran patients. Secretary Collins, a simple question. If a veteran has been raped, is she able to get abortion care at the VA under the current policy, yes or no?
Senator Murray, you know that the VA was, up until 22, was not doing any abortions at all. This was a decision by the previous administration to bend the law, to go back something that had been over generations of both Democrat and Republican administrations. The VA was not in the issue of abortion. That is my simple question. That's my simple answer.
No, a simple question. If you are raped, can you get abortion
There are
care?
no abortions to be done at the VA medical centers except the ones that are the life threatening of a mother. That has been very clear, and that was the process under Obama.
Mr.
It was under
Secretary,
Bush
my
and
time
Clinton.
is
and
out. I
others.
just want everyone to know that under this VA final rule, no exceptions for rape or for incest, and I find that outrageous. Thank you.
Senator, I want it to be known to everyone listening that up until October or till 22, when Secretary McDonough changed what was the high precedent and law of this country, there were no abortions of any kind
Right,
for
and
any excuse or any reason done
And he
in a VA medical
rightfully
center.
corrected that to make sure that if someone was raped or a victim of incest, they could get health care.
I would just
Thank you,
choose
Mr.
to, we
Chairman.
probably see it differently.
Senator Tuberville.
Thank you, Mr. Chairman. Gentlemen, thanks for being here today and testifying. I'm grateful that Secretary Collins, under your leadership, our veterans are finally being put first in this reorganization plan. Mr. Secretary, and Mr. Engelbaum, you might want to follow in on this too. I want to talk about this graph behind me. The red depicts the growth in employees since fiscal year 2019, and the blue shows the number of patients encountered over the same time. Between those 5 years, there was a 14% increase in the VHA employees, but only a 6% increase in patient encounters. Mr. Secretary, my colleagues across the aisle are saying right size in the VA hurts veterans, but this graph doesn't support that. To me, it looks like we're overhired and you're simply rebalancing the books to put more money towards our veterans. Is this correct?
Senator, you are correct. And I think one of the things that we've looked at in this whole organization is, for example, I have a sheet here listing out a hospital that had a 33% FTE growth while only a 14% patient encounter growth. We had a 24% growth in FTE and a -6 in patient encounters. This is what we've seen. Mr. Engelbaum can explain that a little bit further.
Thank you, Senator, and I'll tag team with Mr. Goins a little bit on this, but this is exactly what I said as I initially came on. I've always believed and firmly believed that the VA has provided wonderful medical care. What we haven't done is done that in a cost-effective manner. that's actually done more effectively. And the idea that throwing more employees at something actually increases our effectiveness is actually counter to what reality is. You've got more bureaucracy, more overhead that actually leads to slowing down, and it actually removes folks from actually supporting our veterans. So we've been committed from the outset to do that, to reduce that, to bring that back into balance, and that's what we've done. We stated from the outset, and we looked at our reductions, but that is always tied to veteran care. We are committed to veteran care. We are committed to reducing bureaucracy and making sure that we enforce where that as our standard, not just numbers of people that are employed by the Veterans Administration.
Thank you.
Senator Tupper, could we get Greg Goins on this?
Okay.
Because he actually had to experience this in the field over the past few years.
So there's a couple of reasons why this is really important, Senator. One, we don't have a direct connection between workload and the number of resources we assign generally as an enterprise. That creates a tremendous imbalance where we offer people resources in the facilities, and it ends up becoming a wish list that's not directly connected to the actual demand that the veterans and their families have in that system. The reason that's so important on an enterprise level is when we open a new clinic or an HCC, a healthcare center like in Fredericksburg, Virginia, and we need to add a lot of resources there because it's a new organic location to serve a growing veteran population, we don't have the ability to look at them and say, here are the resources. We ask them to take it out of Hyde. I have to look at a network director and say, you got a new clinic coming on board, figure out where to get the resources, because we factually have not looked at the places where we are losing veterans and tried to right-size the workforce to match the demand. So what we saw at the beginning of COVID is a massive ramp up in resources because we didn't know what the demand was going to be, and I understand that. The same thing happened in the private sector. We did the same thing when the PACT Act came along in anticipation of an increased demand. Frankly, that did not fully realize. We saw more reliance, but not a full workload increase like we might expect. What happened in the private sector post-COVID is they went and laid off workers, and I'm happy we don't do that. However, what we've got to do is understand our organization cannot withstand over time and be sustained with a 14% increase of personnel to support a 6% increase in workload over that same period. It's unsustainable and it's not right for the taxpayers.
Thank you. I got two questions. I'm going to put them into one, but they're very different because you'll cut me off if I don't ask them at the same time. Number one, my state of Alabama, we're 40, I think all over the country, 42% community care. Where does this fit in your reorganization? Because we have to have it. And number two is we need more domestic-made drugs in the VA. And we got people that can do it. But let's start treating our veterans with domestic-made drugs. Go ahead.
Yeah, Senator, thanks for that. Community care is a huge part, and it's also most everybody that's been in Congress for any time voted for this, and it's the law that we have to make community care available. It is a balance out. We're seeing that in our different states. Some use it a little more depending on. And remember, I have to also make sure when anybody complains about a wait time for community care, that is the doctors in the community that are causing that, not me. I mean, so we have to look at that. So, but community care is important. The new contract that we have, CCN contract, Next Gen contract, is going to help us with third-party administrators going forward as we look at this. So I think that's going to address your needs and concerns, and making sure this administration in particular has looked at our supply chains and supply lines so that we can have more American-made products so that we're not caught behind.
Yeah, one thing about community care, I have complaints about community care, hospitals, and the VA's communicating. They've got to communicate better. Well, they're holding back MRIs and things like that. I'm just passing
We'll be happy
along.
to talk about that. Get another question. Mr. Chairman, we'll be happy to talk about the reasons on that as we go.
Okay.
Can I add a comment here? I know I'm over time, sir. I apologize. But the very nature of that HSA, that new element within our organizational redesign, it is meant to directly address that. We have someone that is directly engaged with community stakeholders, to include those community partners, to make sure that that kind of stuff is corrected real time instead of waiting for after the fact and being reactive.
Senator Roanoke.
Thank you, Mr. Chairman. I did want to follow up a bit on Senator Murray's questioning about VA providing abortion services. At the time of Secretary McDonough, it was determined that the VA had the authority to provide abortion services in the case of rape and incest. That is authority that they were deemed to have. So the fact that you are not providing such services is an ideologically based decision, not one, in my view, required by the law. And yes, we all acknowledge that VA is the largest healthcare system, and when we started with this regime, and you came and testified, we acknowledge that, but it was in the midst of thousands of VA employees being fired with little to no notice, and thousands more taking their early, whatever the Doge fork in the road process was. And you had to, you obligated the VA to pay for all these people not working. And in the midst of what could be described as chaos at the VA, while all of this is still going on and questions about even more people, maybe 85,000 more people you were contemplating firing or letting go, you come to us with an entire reorganization of the VA. And it's hard to take it seriously, frankly. You testified just now that there is currently an investigation being undertaken regarding the murder of Alex Preddy. Who is this investigation being conducted by?
Senator, I'm with the VA. You'd have to consult DHS and others on that.
Because neither Homeland Security Secretary Noem or FBI Director has indicated that they are about to undertake an investigation into what happened to Mr. Preddy. The kind of independent investigation that I would say the majority of people in this country are calling for. So since you don't know anything about it, how about expressing your maybe personal opinion? Do you think such an independent investigation should occur with regard to one of your employees?
I agree with the President of the United States, who said it was going to be investigated and will continue to be.
You know what? His definition of investigation is not the kind of independent investigation that we are calling for. This regime is implementing a lot of the items that are in Project 2025. And when I look at Project 2025, what it says about the VA is, a quote, to rescind all departmental clinical policy directives that are contrary to the principles of conservative governance. Now, with this reorganization plan, which this is the first time I'm being presented with any of the information, would you say that, are you following Project 2025 and you want to have a top-down organization that will follow the principles of conservative governance, whatever that means? Are you following that language from Project 2025?
No, Senator, as I said in my confirmation here, and I haven't even read it, and by the way, we're in 2026. I'm trying to run the VA for today. I'm not sure why we're looking backwards to something I'm not doing.
Well, because the president is following and implementing a lot of the items in Project 2025, one of the largest being to totally eliminate the U.S. Department of Education support for public schools. I find it hard to sort of, get that what you're doing is not following what is in Project 2025, which is a very ideologically driven directive on how the VA should be run. And it seems to me that when I look at your reorg plan, what I can make of it is a really top-down kind of organization. In fact, when I visited the VA in Hawaii, he had to go and get approval from, I think, you or somebody that is a totally top-down. And I wasn't given permission to visit my own VA person until practically the day that the visit was scheduled. Is that how it's going to be?
No, ma'am.
I think that is a rhetorical question.
Well, it's not rhetorical to me because we're actually here to explain this to you. And if you would take a ticket to ask questions about RISE, you would figure this out.
Excuse me, Mr. Secretary. It all sounds good. You're trying to save money and all that, but at a time
No, ma'am, I'm trying to help veterans. Let's get the point straight first.
That's good to know.
I appreciate it.
How is helping veterans, how are the veterans supposed to be helped if it's going to be a top-down organization
Senator,
where your hospital directors
hang on a second.
are not really going to have the right to hire people? You have a pause or whatever it is
I
on
don't
them
have a pause.
making those
There's no hiring
decisions.
freeze right now at all. In fact, it just shows to me, unfortunately, that all the information that's been given to your staff and others is not filtered up enough, because if you're saying this reorganization is a top-down approach, then I'm sorry, I'm not sure what kind of charts I can show you that this is not. This actually puts the benefits back at the executive director level in the hospitals. This actually puts our front line. We've had it so
Well,
reversed.
actually, Mr.
We've had it so
Secretary,
reversed, Mr. Chairman and others, that it is actually that.
You know what, the top-down and giving more flexibility to the local hospitals so that they can really
They have
formulate.
it. That's what this plan does.
Care plans.
That's
No,
what it does.
But that was what it was originally, that to have 25 or whatever the number is, that was what was intended, and now you're bringing it back to a very centralized 5.
No,
You see, it
you're
is
missing the
hard
point here.
for
I
me
think,
to
Senator, this is a
understand
great conversation, but you're missing the point. When, as Greg Goins, who's a career VA employee, has stated, the VISN directors were not in a position to actually do the management level diagnosis that needs to be happening. So now we're having management level at 5 where they can do the management levels for the divisions, while we have health service areas who actually are able to talk to your hospitals in Hawaii and other places. If you look at this plan, I would welcome any disagreement except for one, and that is the fundamental wrong statement that this is a top-down plan.
Oh, that's what it looks like to me. And you can say all the things that you want, but it's all in how it's going to be implemented. And to come up with this whole reorganization plan at a time when there's basically chaos in this regime, it's pretty hard for me to, it's pretty hard for me to kind of say, oh, well, I think this is really a great thing that you're doing on behalf of the veterans.
Senator Kramer.
Mr. Chairman, can I answer that last? In the midst of chaos, it is amazing to me that we've cut the backlog. It's amazing to me that we've actually lowered wait times. It's amazing to me that through this process, we've made it easier for our veterans to get this health care service they need. If that's chaos, maybe we're in the right direction.
Senator Kramer.
Yeah, thank you very much, Mr. Chairman. I wouldn't normally do this, but something I did in my previous life was I taught MBA students management theory and application. And let me tell you, the notion that top-down flexibility, that those two terms don't even go together. What it looks to me like is you've flattened the organization. And so I want to get specifically to what you just brought up, Mr. Secretary, because I frankly am pretty certain a bureaucrat made a mistake. Because there is no way that you could have made the agency so efficient that you could come into this mess right here with 264,000 backlogs and turn that into 105,000 in 1 year. So please enlighten me as to how that actually happened or who made the mistake.
There's no mistake. That is true. And it was put forth by our VBA, who actually came to us and said, we can do better in this, because I asked the question. And for those on the committee, you know this, and for staff who may be new, 125 days is our standard for a backlog claim. In other words, it has to be 125 days before it even goes on the backlog. So think about that for a minute.
Yeah.
This had grown up exponentially over time. And also, by the way, when I first came in last year at 264,000, there was also over 1 million claims in the pipeline. That now number is closer to 600,000 to 550,000 in the pipeline. We've been able not only to take the backlog and reduce it, but we've actually taken the total number as well. Now, there's been some false rumors thrown out that quality is suffering about this, and there's been other things. The truth of the matter is that when you have that much more cases being actually adjudicated, there will be people who appeal their adjudication. Not everybody's going to get 100%. Not everybody's going to get what they want. So what they have happened is there's again, I think a 3% difference in the number of appeals on the lower number that was being decided as to the higher number that's being decided. So this is done because great VA employees at the VBA saw the issue, they wanted it measured, and they got it done.
Well, I know this, if I'm really critically ill, if I'm sick, waiting 125 days to meet to see a doctor is not an enhancement in quality of care.
Yeah, this is their benefits to get there.
Oh, their
yes.
benefits.
Yeah, the benefit side, and this one is one that everybody looks at to start with.
Sure.
So it's our
But it kind of amounts to the same thing in the end. If you have the uncertainty, the angst, the anxiety of not knowing whether you're getting your benefits, and you wait 125 days, that adds to the problem, not the solution.
Can I share you something? It's even more, and I want this understanding. Again, this doesn't have to do with the reorganization we're doing now, but you need to hear, and the whole committee, I want to hear this, that we've been able to take this number not only down to 100,000, which we're going down even further, but average days to complete. That means how long did it take somebody to file a claim and get it completed? Was it 135 days last January? Okay, 135 days. That's down to 80 days now. And my staff tells me that if we can work with the Department of War to get the files transferred quicker from DOD, we could actually see legitimately within this year a 30 to 35-day turnaround time on disability claim. That's a win for veterans.
I love it. Okay, I need to make another point and ask a couple more questions with my next chart here. And that, you know, we've heard a lot of these insinuations about how right-sizing the VA is forcing or pushing veterans out to community or to community care. But I want to point to this board that we create. I think it's 25 VA clinics have opened since January 20th of last year. So once again, so backlogs are down, employee numbers evidently are down, and yet there's 25 more VA clinics. I mean, again, did somebody make a mistake, or how did you pull this off?
No, I think it's just, you know, like I said a few minutes ago, and I don't mean this to be anything, but if this is disorganization and chaos, then I want to see more of this, because we're opening the clinics. And go ahead.
Well, I want to point to the rectangular blank spot in the middle of the North American continent called North Dakota. Okay, there are two new ones there, one in Williston and one in Grand Forks. Now, the beauty of that is that those two communities are 333 miles apart, just so you know. 333 miles, and that's just straight across. In other words, there's a lot of space between those, which gets to my point of the legislation that Senator Sheehy and I have introduced to incorporate critical access hospitals, of which we have 37, and I will show you a larger map of just of North Dakota so you can see where they are. I just, you know, we have all these communities far from a CBOC or a hospital. We would, as you know, in our legislation, like to utilize these critical access hospitals in a more efficient way that both makes them better and provides better care to that local veteran.
Senator, we're on board with you. I agree with that asset, and that's one of the things we're looking for, is to partner with rural hospitals. Real briefly, our Undersecretary, is this a passion project for him? I want to address that because it is something we see needed. Also, Senator Duckworth actually brought this up a long time ago about co-locating some of these facilities, and I agree completely with you on that.
And Senator Duckworth, I appreciate the conversation we had the other day on this, and several of us have had this conversation. Mm-hmm. I've actually, you know, been confirmed now for a couple of weeks. I've already asked the team to look at what, if any, restrictions are there for us to do some of our leases with them, the community access hospitals, because I believe that it is a double win, because it helps support the facility itself, and then it supports our veterans where they are, and partnering with them to be part of our TPA network, our clinical care network, because even as we do this reorganization, the clinical care, the contracts, that's still going to be part of VHA. We're an integrated system. You have to have inside VHA, you have to run and manage the clinical care hospitals, or the contract for community care, and you have to run the hospital system. Sure. But we're working on that, and I just want to say, I'm actually going to Ohio this weekend to open up another facility, and we have another 20 scheduled for this year, if I've got the number right.
Well, Mr. Undersecretary, I'm just glad that we could reduce our backlog here at the United States Senate of confirmations for you as well. Thank you, Mr. Chairman.
Senator Hassan.
Thanks, Chairman Moran and Ranking Member Blumenthal, for this hearing, and thank you, Mr. Secretary, for being here and for your testimony. As many others have done, I'd also like to take a moment to reflect on the fact that Alex Preddy, a nurse who worked at the VA and cared for our nation's veterans in the ICU, was killed this weekend by masked federal agents in an outrageous escalation of unacceptable behavior by this administration in recent weeks. We urgently need additional oversight and reform over ICE's behavior, because what is happening right now in Minnesota and in states across the country is making us less safe, and it needs to stop right now. So I hope my colleagues on the other side of the aisle will work with us to keep the government funded and protect basic American freedoms. And I will add, Mr. Secretary, that you mentioned an investigation. When there are officer-involved shootings in any other law enforcement agency in this country, pretty much local or state, the officers involved are put on administrative leave, and an outside agency comes and does the investigation. So those things need to happen. The roving patrols need to get out of Minnesota while they mourn these deaths and while the investigation is pending. Now, Secretary Collins comes to the business of today. I'm going to ask you a question that I asked a VA official who came before this committee in December, and I'm hoping that you'll have more information to provide than he did. Last May, President Trump signed an executive order that required you to direct a feasibility study and create an action plan regarding bringing a full-service VA hospital to New Hampshire. The action plan was due to the president last November. In a November 20th letter, my New Hampshire colleagues and I asked you to make that action plan publicly available by December 1st so that my constituents can review it and give their input. Secretary Collins, when will this action plan be made available for Granite Staters to look at and provide feedback?
Senator, there's no one else more anxious to get that action plan than I, and at this point, we're still putting it together. I think that is the Undersecretary's role to this. So there was some setback during the shutdown that did delay this action. I'm hoping to get, frankly, I'm hoping to get it to you as soon as possible.
Well, that would be good because it is way overdue,
understand.
even
Yes, I
understanding that the shutdown.
And I agree with seeing it up there as well.
Yeah, it was
Yeah, I
good to
saw
have
the
you up
need.
there, but the need is there. People are anxious to consult with you
I
all.
agree.
Now, you and I have previously discussed staffing at the VA and the need to make sure that our veterans have the best staff and the right number of staff to ensure that they get the highest quality of care. You all have talked about that today. It's recently come to light that the VA is planning to permanently eliminate up to 35,000 positions, most of which are currently vacant, including doctor and nurse positions. The doctors and nurses aren't overhead. They're doctors and nurses. So this is in addition to the nearly 30,000 employees that VA lost last year. In an article discussing this plan and other VA actions, one VA nurse was quoted as saying, "We're going to continue to do more with less. We're going to continue to be overworked." So I'm concerned that these staffing cuts could leave the department in a position where it may not be able to care for our veterans moving forward, especially as more PACT Act veterans come forward to receive more care. And frankly, Senator Tuberville's chart raised more questions than it answered. So, Secretary, what analysis has the VA done to ensure that the elimination of these positions will not affect veteran health care, not just now, but in the future as well?
Thank you, Senator. And that's why my HR person is here, and also Greg Goins from a practice center will explain that to you.
Okay, quickly, please.
Senator, I'll start off. I want to make sure again that we don't conflate personnel and authorizations or positions when we talk about that. When we talk about that, and Mr. Goins mentioned a little earlier, for years we've had a process. Congress, you yourselves have been asking us for years to produce a unit manning document to provide position numbers, structure, how we're organized. The VA hasn't done that.
I'm just trying to, sir, I'm running out of time and I have one more question. So
Sure.
I'm just trying to understand what the process is.
We have a very detailed process. We put this in the hand of our operators, the VHA, who determine the requirements. What they are doing is going through and identifying what they need. We are removing empty, vacant billets that have been created at a very low level many times, that have been put on the book for years, that have no funding, no authorization from you to fund, that have been just sitting out there that are masquerading as
All right,
billets.
I will follow up with you on that. I will also say when there's a lot of uncertainty and a lot of announcements of layoffs and cancellation of contracts and back and forth, it doesn't make people eager to come work at the VA.
That's correct. And if I can just add one thing, Senator.
I've only got a few seconds left, and I got to get to this next page because it's relevant to what you just said. As part of the changes that VA is undergoing, I understand that you're also looking at placing caps on the number of employees that each VISN can hire. That was something that was confirmed during committee discussions in preparation for this hearing. So I'm concerned that these caps will affect the number of employees that can be hired for new or expanded VA facilities, like a new hospital in New Hampshire. So, Mr. Secretary, will you commit to hiring more staff to support the expanded care and services that will be available for Granite Staters, we hope, when this full-service hospital finally comes online?
Yeah, I would be happy to let Greg answer that because he's actually had experience with what you're just talking
Okay.
about.
So this goes back to what I was talking about when Senator Tuberville put up the chart.
Yeah.
We have never had a strategic approach to enterprise resource allocation to do exactly what you're asking for. The reason that we have asked our operators in the field, and that's our medical center directors and their executive leadership teams, to evaluate people on board and number of vacancies, whether they're in recruitment or not.
So yes or no, caps on number, because look, I've managed large organizations too, right?
Yes.
And here's the deal. You analyze from the bottom up. You don't put arbitrary caps from the top down.
Right, but you also do an affordability. Any business in the entire free world, you can't just keep adding resources if the demand
We're
against
not
those
a
resources.
business. This is a care agency for the people who gave us our freedom, and they deserve every investment we can give them. And I am proud to work with my colleagues on both sides of the aisles, but we need to put our money where our mouths are and protect the people who protected us. Thank you.
You're correct. My time in Afghanistan and both of my brothers being deployed in the same theater says the same thing on my end. But the point is, when you have a new hospital that comes into New Hampshire, as an enterprise, if we don't have a strategy to be able to look at your people and say, here's the resources to run it, you're robbing Peter to pay Paul. That has to be fixed.
The strategy is fine. Arbitrary caps, which were described to our committee staff, are not. Thank
Senator,
you.
may I, if I can address the caps? When we talk about it, and I mentioned before, we didn't have a unit manning document, and I know this a little bit in the weeds, but what we had to do is start creating that. How do you create your structure, to what Mr. Goins was saying? So what we did is we asked what the requirements were for VHA. So for example, they came back and said, we need 1,000 people. I'm just
Yep,
thing, right?
example,
So
right.
basically, they said this is our requirement. Now, if I set my requirement at 1,000, okay, I can't put 1,000 positions on the books because I'm going to have a lapse. That lapse rate is somewhere generally between 7 and 9%.
Right.
So what we did is we took their requirement, which is, let's say, 1,000. We inflated that by about 9% for VHA to say this is now your UMD, so we can create an initial UMD. That cap was set at the requested authorization by VHA to do their mission.
Thank you for the clarification. I'll follow up with you because what's really important here, obviously, and I will take you all at your word, is that we have the services and the care for veterans that we need.
Yes, Senator.
And look, you guys got off to a start where you did you announced a huge number of layoffs, a huge number of cancellations, and we couldn't get any information about any process behind it. So you're at a trust deficit with us right now.
Senator Sullivan.
Thank you, Mr. Chairman. And Mr. Secretary and your team, I want to begin by thanking you on the focus that you're bringing to our veterans. In particular, I appreciate the shortening of wait times for access to health care. In my state, you brought the backlog, which got really, really high during the Biden years, down to a much more workable level. I know you've been putting a lot of effort into that, Mr. Secretary, you and your team, so thank you for that. And I know what you're trying to do is deliver better care. You're doing that with a genuine heart for our veterans, as a veteran yourself and still serving, actually. So I want to thank you and your team for all this. It's not easy work, right? This is the biggest bureaucracy in D.C., and a lot of people have tried to reform it, and it's a challenge. I want to start by, as you're working through the restructuring on the healthcare side, and I know it's a big undertaking, I have some questions, but the one issue I want to make sure your team continues to focus on, and we've talked a lot about it, is community care. And that is deeply important to Alaska. As you know, Alaska has direct access to community care because of a provision I included in the 2018 Mission Act. And a lot of the VA, if they're not VA officials in Alaska, they don't get that, right? They don't remember that. The provision applies to states without a full-service VA hospital. That's Alaska, it's New Hampshire, and I believe now Hawaii. I'm not sure what the status of Hawaii is. And so that's just in the law. And during the Biden administration, there was an internal memo which tied bonuses to keeping veterans inside the VA system. Now, look, I have no objection to veterans receiving care within the VA system when that works. But as you know, Mr. Secretary, in my state, it doesn't always work. And the law says, hey, the veteran can go out and get community care, period. That's end of the story. So how are you making sure that we, as you're doing the reforms, that you're going to still focus on community care, because it's really important, and the last administration tried to put their thumb on the scale on that, even though the law said my veterans get to go into the community to get it because we don't have a full-service hospital. And by the way, we got more veterans per capita in any state in the country in Alaska.
Yep. Senator, the community care aspect is actually will be enhanced by this, especially with the HSA part of that, actually looking at the needs of individual hospitals. We have several that, if you go to New York City, you have 4 or 5, within just a number of square miles, all urban, all a highly density area, which has a different need than, say, in Alaska, which has the no hospital, but also has a lot of community care. This will actually give us a more hands-on approach to looking at how each of the systems operate as we go forward. And then our new community care contract, which is, was required to after a number of years, is being led in a way that is going to enhance our ability to do third-party and expand our third-party network. And if you're just a second, Mr. Bartram would like to answer a little bit of that as well.
Yeah, sir, there's no plans to change anything relative to
Good.
the community care
really what I
structure.
wanted to hear.
I mean, as the undersecretary, both community care and the direct care system fall under my preview on behalf of the secretary. And that will happen even after we go forward. The community care contracts will still be ran by us.
Good.
It's our program. And one of the things that I want to point out is, as you know, and you've been actively involved in the decision that the secretary made last May on best medical interest. And the best medical interest of allowing veterans to be able to go out to the community when it's the best medical interest of their doctor, which is even outside of the flexibility the state of Alaska has, that's increased by 66% because of the decision.
Good, because at the end of the day, that's what we want, better care for our veterans,
right.
no matter how you get it. Let me ask another quick question, and this is going to, Mr. Secretary, you and your team, I'm going to, I have skepticism of VISN realignments. The last major one that took place, which went from 21 to 18, completely overturned the system in Alaska. It was an unmitigated nightmare. That wasn't you guys. That was a long time ago. I've spoken many times about the unique challenges. I still want to pitch to you and your team, even as and we're working closely, and I appreciate the outreach with my staff, but I want to continue it. But to look at Alaska as a separate VISN. I know this is something that you haven't agreed to yet. That, and then on the HSA issue, we were told, well, if you're not your separate VISN, because you're very unique challenges, and you've had challenges when there's been VISN reform before, it really collapsed the system in 2015 and 2016 in my state, that at a minimum, there would be an HSA solely committed to Alaska. And then we heard from your staff, well, maybe the HSA is going to be combined with Hawaii. No offense to Hawaii, I love Hawaii, but we don't need to be combined with Hawaii. That's not a good idea. And I don't even think Senator Hirona would like that idea, right? So I'm still pushing for some structure that gives my state some ability to have you guys look at the unique challenges, because whenever we're put in the place with other lower 48 communities, it's so different up there that mistakes get made. And the last time this happened, it wasn't just a mistake. The system collapsed in my state, and thousands of veterans were not served. So can I get your commitment, Mr. Secretary, and your team to continue to work on advocating for this? I know you're looking at it. I know you're skeptical, but I am not done making my arguments with you.
Well, I've learned from my Air Force career and also my previous, when I started the Navy, work with my Marines, I don't continually to go up against Marines and not try to at least find a solution. So we're going to continue to do that, Senator, as we look forward. And that's one of the reasons we're here today to
I know,
explain
and
this.
I get it. And look, I appreciate you coming. You get worked over in this committee, and you're taking it, and that's part of the oversight role, and my colleagues on both sides of the aisle do. But you do it with class and dignity, and your team's heart is, in my view, in the right spot. It's about taking care of veterans, number one, number two, number three. That's what the VA is all about. So if I got your commitment to continue to make the advocacy for my state, that's what I want. So
Senator
thank you very
Gago.
much.
Thank you, Mr. Chair. Well, first, I'd like to just take a moment to acknowledge the life of Alex Preddy. He was a VA nurse. For us that have used the VA, we are lucky to have men and women like him who take care of us in some very, very tough times. And it's a sad situation that he was murdered. But let's remember for his dedication. Remember him for his dedication to his country and to many of us veterans that use services with the help of people like him. moving into Arizona, where I worry about my veterans there, there's a new 30,000 square foot VA medical facility in Yuma, set to open by summer of 2027. We talk about overrepresentation of veterans. That's a big community there, and it's rural also. It's supposed to provide comprehensive local care for veterans and reduce the need for travel. So services will include primary care, women's health, therapy, lab and imaging, optometry, and audiology, all in one location, which is great. However, under the new staffing caps, the Yuma facility would not be able to hire any new staff. Their only option would have to be pulled from other understaffed hospitals, and Arizona is still a growing state. So how can you guarantee that veterans in Yuma will be able to get medical care if these staffing caps are still existing? And how can I look at my constituents and tell them that this VA does not really understand that you're going to be essentially robbing Peter to pay Paul, and potentially not creating a fully functioning system in one place and or another place?
Yeah, Senator, you're one of the reasons I think an underlying secondary reason, if you look at it, your state along with the whole Southern is why we're doing this reorganization. And Mr. Goins talked about that a minute ago. I'd like him to explain that a little bit further, how we can actually reallocate assets for those things.
So I know you're talking about Arizona, and I know that's important to you, but I'm going to use a couple other examples where we have a similar effect. Nashville, Tennessee is one of the fastest growing markets in the country, along with the areas of Arizona that you've discussed, along with that whole southeastern Sun Belt area. The problem we've experienced in the past is because we have not created a system that ultimately aligns resources in the way Mark described, a Manning document, if you will, with the overall demand and needs for those growth areas. We have created pockets where we have far too many, in theory, resources. We've got to take our time to make sure that those are allocated appropriately on an enterprise level so that we can then reallocate resources in places where veterans are moving. And we know that happens to be in that same market. Veterans are a microcosm of society. So as a result, the goal is not to take what you saw go out saying this, again, based on what Mark said, this is based on overall needs of the system and use that in perpetuity. Over time, that changes. And if we see a higher need in a market like Arizona or Nashville, et cetera, some of those high growth markets, then the expectation is as an enterprise, we don't ask local markets to rob Peter to pay Paul. It's about assigning resources.
So, and just to further that, the question is an issue of timeliness then, because it's good in theory, but then, government's not known for making decisions quickly, nor big bureaucracies. So, we're going to be opening up that VA facility. At the same time, you're starting this new process. And what I fear is there's going to be just an absolute drop of that. Now, moving on, kind of also related to that. So as of 2 weeks ago, the average wait time for new VA patients for individual mental health appointments in Arizona was 51 days. And I don't have to tell you guys, especially from my personal experience, when people have problems, we need to get them in to see somebody. The national average was around 35 days. So what is happening in Arizona that we have that 16-day difference, and also growing from what I understand, which could be extremely dangerous, to prevent, the veteran suicide or other problems?
So in short, I'm not showing, again, I think there's a discrepancy in what you guys are presenting and what was presented earlier from Senator Blumenthal. I'm not showing the current national average of what you just said.
What is your natural average?
New patients or established patients?
New patients.
New patients are at 18.8 days as of yesterday.
And for Arizona?
I don't have Arizona sitting in front of me, but I can look at that and we can get back to you. Now, here's what I'll tell you. In almost every single market where we have extremely high velocity of growth for veterans, the wait times are more challenging there than anywhere else in the country.
No, I understand that, but then now you have this program where you have caps and you're not going to be able to necessarily react into the timely manner when you have, if you want to call it market demand. And unlike, business, what you're talking about is potentially lives of veterans that are on the, knife's edge of suicide. So, these are all really good MBA ideas, but when you're actually dealing with real people, this gets very dangerous. And
Senator, let me I agree with you, but let me also just point out a fact that we're looking at we talk about FTE calculations, we saw with the numbers. In Phoenix itself, the number was 24% FTE growth over the last 5 years, 11% contact with the patient. So 11% not only went up 11%, 24% FTE growth. In Northern Arizona, 39% FTE growth at, again, only 11% actual contact. Southern Arizona, 18 to 2. These are showing that we can, and this is why we need this system to be able to move people where they need to so that we can handle areas such as yours. So
Look, and
again, I know it's all in the middle, but we're working.
Right, so FTE doesn't necessarily mean that it's the appropriate people that are actually dealing with mental health. It could be the janitor, things of that nature. So
Exactly.
So I just want to make
You just
sure.
hit why we're doing this.
Yeah.
Thank
Well,
you for
I'm
that.
not sure it's working in the way in a timely manner that's going to bring services to the people as they
So
need it.
If I could say real time, because it is somewhat sticky, right? I said earlier, private sector, they just lay people off. We're not going to do that. So over time, we have to do it kind of through attrition where it makes sense. In the meantime, what we have told our facilities and our network directors, if there is a critical need related to direct clinical care, put your hand in the air. Give us a call, and we will make sure that you have the resources that are needed to care for veterans.
Well, I'm just going to go ahead and tell you right now, they're going to need that in Yuma right away. It's hard and difficult to get people to move there because it is a desert, it is rural, so it's going to be extremely difficult to get people to volunteer to move there, and I think it's critical that you get ahead of that and not wait for a demand signal to come.
Thank you, Senator,
Yield
for
back.
bringing it up.
Senator Sheehy.
Electronic health records. Go.
God, I love my seals. Electronic health records management, as I said last year when I was being confirmed, was an absolute and unmitigated disaster. It come through 2 administrations. In fact, the previous administration just frankly gave up, threw their hands up in the air and said we quit after billions of dollars being spent. I promised this committee last year when I was sitting in this table that we would that would be one of the first things I addressed. I did exactly what I said I was going to do. I sat down with our people first and I said, what's the problem? I heard all the whine, moan, bitch list that everybody had. Then I took it and I went to Oracle, who is the provider. And I said, okay, tell me what your problems are. And they wanted to blame us and they told us what their problems were. A week later, I sat them both in the same room and said, okay, let's talk. They began very friendly back and forth until I started telling them what one said about the other, and all of a sudden we got real. Then I set them in a room for a time to say, okay, let's get this together and figure out a plan. After 2 days of sitting in a room and figuring it out, we figured out that, number one, VHA had way too much non-standardization in their plan. In other words, where we started in Washington State, which Senator Murray and I have talked about, which is a disaster, they were allowed to basically design their own systems while the Cerner at that time was just enabling it and letting it happen. So they can't talk, they couldn't do anything. We have had over 5 years of study looking at what happened and went wrong. After that was concluded, I said, we're going to standardize our process. We're going to standardize what we do. VHA is no longer going to be the sticking block here. We're going to get to 90% of what the standard product is that we're being offered. The 10% where we need to customize, that would be the only part we did. And we began the process. After this Senate confirmed Dr. Lawrence to be our deputy, which is statutorily under his realm, all he basically has done is went to Michigan and to Ohio and to Alaska, and we got Indiana that are up. April 1, we go live on the Michigan sites. They have been working for a year now or longer at this. We have had consistent reports. We have consistent metrics and data, and Dr. Lawrence has personally been to those sites multiple times. So that for the first time, I can report to this committee that we've actually begun to put an EHRM system in place that will help community care, that will allow the doctors to send in their, not only get paid, but also send in the medical records and medical charts. It'll allow us to, inside a system, to actually be able to talk to each other, which we can't do right now. This is the first step of that, and our hope is that when we come into this after April, we get into June, and then later this summer, we'll have a momentum built up for our next phase of 27. For the first time, there is an honest plan looking forward. Now, if everybody looks backwards in this, I understand. You have every right to be skeptical. Every right to be skeptical. But all I can tell you right now is unlike anything in the past, I have set my eyes and focus on getting this done because I knew it's where we needed to be. We put the resources and the capabilities there, and this will get done, and it's going to be done in the right way. And I welcome any senator, anybody on the staff to ask us questions, to get Dr. Lawrence. I will make him available to anything that you need.
Thank you.
Thank you, Senator Sheehy. You were quicker than I envisioned, quicker than anybody else. Senator Slotkin.
I should have talked.
Thank you. similar, there's bipartisan concern
Exactly.
about the electronic health record
Rightfully
modernization.
so.
You mentioned Michigan. We are set April 1st to be the next state. And I'm going to take you up on this offer that you just made to have Dr. Lawrence come and brief our bipartisan congressional delegation, because I think from both Democrats and Republicans in my state, we are concerned that we have a little bit of a perfect storm. One, you decided to triple the number of locations that are going to go through modernization this year. So we feel like in Michigan, maybe we won't get the attention, that we need. And you're right, Washington was a disaster. Number two, we have over 1,000 vacancies right now at our 4 VA hospitals. Some of them say they're having trouble getting waivers to hire people to help with this. We need to speed that up. And then number three, we haven't seen you guys fully implement all of the VA's IG's recommendations. If I'm wrong about any of that, please just agree to have Dr. Lawrence come and brief our bipartisan delegation. That's all I want is permission to do that. I want to talk about other things. So if you're willing to have him come down, just tell me so, and we'll pepper him with questions.
Okay, set the date.
Great. We will set the date sometime before April 1st.
Also, can I say one thing? I'll make it quick, I promise. OIG reports and recommendations were based on a screwed up, backwards system that is not in place anymore. So anything that's referenced to the OIG report, in all fairness, is like looking at a 1945 novel and not describing
That's fine.
it
I just want us to have Democrats and Republicans from Michigan be able to ask questions to the guy who owns the transfer, okay? Now, I want to turn to the topic my colleagues have been talking about, which is Alex Preddy, your employee, the ICU nurse who was killed over the weekend by Border Patrol. You said in your opening statement that you weren't able to engage on this topic, but you did engage on this topic. It took you 30 hours to put something out on Twitter about his death. First, you put out something with penguins in Greenland, but then you put out a statement that said, quote, "Such tragedies are unfortunately happening in Minnesota because state and local officials' refusal to cooperate with the federal government to enforce the law and deport dangerous illegal criminals." Was Alex Preddy's death the result of the mayor of Minneapolis or the governor of Minnesota?
Alex Preddy's death was a tragedy, as I've stated, and I will continue to stand by that statement.
Okay, but you put it out under official VA Twitter, right? This wasn't like your personal opinion. You weighed in and said why he died. And let me just ask, right? He was your employee. You know that people who work for the VA can't just walk in. They're vetted. They're properly vetted. We had other cabinet officials call him a domestic terrorist and an assassin based on your access to the information you have in the VA and in front of 460,000 VA employees. Was this man, in your estimation, a domestic terrorist or an assassin?
What I have said about this as being a tragedy, I will continue to say, and I'm not going to make a characterization on something someone else said.
It's not. You said that it was the result of local officials blocking their access. You said it. It's not someone else. So if you can't say
I made no characterization about Mr. Preddy.
You said that his death was the result of, quote, state and local officials' refusal to cooperate with the federal government. Not my words, yours. So you are prejudicing this investigation. You are weighing in on what you think happened. And I just think in front of the employees who have been through a lot this year, that you should at least be able to say to his family that he's not a domestic terrorist or an assassin. Right? People have eyes. They see the video there. And I think we owe him more than that. But to say that you can't engage on it, to say that now that Donald Trump has told the cabinet that now it's okay to have an independent investigation, and all, Secretary Noem and Stephen Miller have to walk back what they've said about this poor man in front of his family. Now I think you can admit that you joined them in prejudicing the investigation of your own employee. And now, can I ask, I understand there was some sort of memorial event yesterday that was held at the VA in Minnesota. Can you say clearly that neither you nor your senior officials tried to stop that memorial from happening?
We did not.
Okay, because there's an email circulating online right now that says that they were told not to have the memorial and the people went ahead anyways. So I hope that when this email comes out, there's not any of you sitting at this table who had anything to do with the fact that they wouldn't be able to celebrate the life of a man who was killed. Can you speak to that?
I can. I've seen the email. That email did not originate from my office or anybody sitting at this table's office. That came from a leadership official in Minneapolis.
And so he just woke up, the man who, or man or woman, I don't know, who employed this man, who's dealing with all kinds of fallout and, terrible feeling when people lose that person just woke up and just decided to say that someone else, the higher ups, told her not to have this memorial. She just made that up?
I don't know that she made it up, but I can't tell you what her perception of anything was. But what I can say is that we have been supportive in an appropriate time to be able to have a period for their employees to memorialize Alex Preddy. And they did that yesterday with almost 400 people.
Well, I hope
at noon, which was scheduled.
You see how it takes a suspension of disbelief to believe that the woman who is the supervisor of this poor man said that higher-ups told her that she couldn't have a memorial. It seems a little hard to believe, but I yield my time. I'm done.
Senator Banks.
Thank you, Mr. Secretary, and to all of your colleagues for your leadership, what you do every day to focus on serving our veterans. And especially thank you, Secretary Collins, for we've had many discussions and your leadership and what you're doing to work with me to move the Indianapolis Replacement Medical Center and the Hamilton County Outpatient Center lease forward in Indiana. These projects would replace a really old downtown medical center with a new medical center and an outpatient center that's closer to where most veterans in the state of Indiana live. And I wanted to ask you, Mr. Secretary, can you talk about how this innovative approach could better benefit veterans in the state of Indiana?
I'd love to. I think this innovative approach, especially when it comes to the two-pronged effect of not only direct care, but also community care as well, which is something vital to your state, just as it was when I represented the state of Georgia. It's something that we've got to work with our partners on in making sure we get the veteran the best care that we possibly can. The best solution that I can give you on how this can actually work is from, what we've talked about today, but Greg Goins was actually on the field. A lot of his input came from what you're talking about here, because it wouldn't have been Kentucky and into the thing. I would like for him just to address how this is going to make really this integrated care better as we go forward.
Please.
Yeah, so the overall integration of care model in the new structure is one that really hinges upon that HSA relationship. What we have right now is you have a network director that oversees Ohio, Indiana, Kentucky. Yes, they have aspects of your care and the areas that you're talking about specifically in their wheelhouse of responsibility, but they're completely pulled away with some of the oversight responsibilities here in DC. So as a result, the new HSAs, their sole function is going to be able to understand that and advocate on behalf of Indiana veterans in this very specific way.
I know that y'all can't talk about the president's budget request in advance, but Mr. Secretary, I do appreciate that your team has shared that these projects rank very high on the VA's priority list. The next thing we need is the outpatient center lease to go into the FY 2027 budget. Is there any obstacle preventing that from happening that you're aware of?
When it comes to budgeting, that would be all here. Nothing from our perspective. I think we've made, clear on our intentions and things that we, the stuff that has been inputted from our perspective, but then we defer to this body and others to get that finalized in how they would like to see it.
Good. Turning to your RISE initiative, Indiana touches 4 VISNs, as you know. Most of Indiana is in VISN 10. Northwest Indiana is in VISN 12. Part of Southwest Indiana is in VISN 15, and a lot of veterans in Southeast Indiana go to facilities which are in VISN 9. So you see the patchwork that we have. How will consolidating the VISNs improve coordination of care in Indiana?
Well, again, this is one of those things when you look at it from a perspective of, crossing lines, and it goes back to the very issue that we were seeing in how you get answers that are consistent across VA, and this is something that really actually helps that. I'll let the Undersecretary Greg handle the rest of it, because that is something we need to look at.
So Senator, as somebody who grew up in Evansville, I fully understand where you're coming from on the coordination. But that's why having the larger VISNs allows for resource across that larger geographical territory as they focus on the strategy and the resources. But in the HSAs, as they focus down on the markets, and we haven't identified what all the HSA delineations are going to be, but the markets can be tighter so that they can focus on an area. I'll pick on my area where I grew up, since from Indiana, the Evansville, Vandenberg tri-state area with, the Henderson, Kentucky area, that's a market, and that's an area. And so as the HSAs, they can cross over those boundaries as they go out, but they're really going to be able to focus on the market aspect of it. But even today, as you know, there's not a policy barrier to prevent somebody go from one VISN to another VISN because it's the veteran's choice. Although I would contend that sometimes that's the perception, as Senator Moran pointed out earlier, that veterans will get those types of messages because of the broken nature of the policy distribution across the system. So I think this will help us focus on that. And to the right of me, it used to be the VISN director in the Louisville area, Kentucky area. So you may want to chime in a little bit more.
Yeah, the only thing I would say is veterans will continue to have a choice where they want to receive their care. And if they're in southern Indiana, that might be Louisville for specialty care, and I think that you would prefer that as well. What I think is the challenge in the current system is if a veteran in Indiana has an issue, you don't know which VISN you have to go to or which VISN you want to escalate concerns with. So to what Mr. Bartram mentioned, Indiana right now is seen in that larger VISN at a like upper Midwest group of states. And so that would have a singular place for you to go for conflict resolution when a veteran has an issue. So I think it's the best of both worlds, frankly.
Got it. Thank you. My time has expired.
Senator King.
Thank you, Mr. Chairman. A couple of questions about the reorganization. I think the first thing, Mr. Secretary, and thank you for being here today, is this a done deal, or is this a work in progress? Is this a draft that we've seen, or is this completed to be implemented?
This is majority is a moving forward of the completed issue. That's why we've been, over the last month, discussing with members of Congress as well. There are still some things that we need to work out that even our own people are coming back with and saying, okay, after looking at this, then we're going to continue to change some things. So there's some changes, smaller changes. The overall structure, the overall vision of how we're going to take this is where we're moving forward.
Let me follow up on that, because just from a 30,000-foot level, I don't really understand how we're flattening the organization by essentially inserting a new layer. Now we have 18 VISNs. They're going to go to 5. We have 0 HSAs. We're going to go to 15. We're going to have fewer VISNs and this new thing called an HSA. I don't understand why we can't simply reorient or change the structure of the VISNs rather than create a whole new level. Seems to me we're reinventing the VISNs from where they were 25 or 30 years ago.
Not really, Senator, and I think the problem here is an understanding of what goes back 20, 30 years ago for those who would go back and look at the history of the VISNs and where they're supposed to. Remember, the VISNs at one point in time were not going to be any bigger than 10 to 15 people. Some now actually have literally tens of thousands of people associated with a VISN, which was never intended to be, which is one of the problems that has existed on how you can't get answers out of there. This was one of the, again, key issues for how do we make the executive directors in our, this is what I talk about not being a top-down. This is about the center directors and the clinics being able to get direct answers with that. That was part of what Greg was tasked with, is looking for that, and can answer that a little bit further.
So you have to, if you just look at this on a baseline level, according to what you just said, you could easily make an assumption, which I think would be a mistake, to say that's just adding a layer. Ultimately, this is a fundamental change in the way in which we deliver care, in the way in which we provide support for those that deliver care.
No, so it's a fundamental change in the way the organization of the structure is.
No,
but
this
you're still going to have VA hospitals, CBOCs,
yes,
community care.
This is a fundamental change in the way in which we provide support to those medical centers. Currently, we have one person over a VISN, whether it's 18 or maybe we reduced it to 10, and they have a bifurcated responsibility, one in which focuses on governance, appropriation allocation, and all the administrative things that have to happen through DC, which still needs to happen. For every day that they spend doing that, which is a lot, having lived in that world for multiple years, that's less time that you can spend to actually engage with the facilities providing support
But
and
couldn't you
oversight.
just have a deputy in each VISN that
Yes, you absolutely-
bifurcate that responsibility and instead of creating a whole new layer of I hate to use the word bureaucracy, but that's what it looks like.
You absolutely could do that. You could do a bifurcation. The problem is they're still pulled in both directions. A deputy still has to do some of the aspects of what I'm mentioning. This also came from market research. We met with for-profit, not-for-profit, government, and private sector healthcare entities and when we did that market research, we evaluated their organizational structures. This is what is considered a best practice so that you can specialize on the quality and oversight of care delivery as a singular responsibility. That does not exist currently.
I'm a little skeptical, as you can tell. I commend you for trying to reorganize and improve the delivery of services. Nobody would quibble with that intent. So I just want to continue this conversation and be assured that this isn't going to simply have another layer and have I just want to be sure those hospitals get what they need. Second question in a very short time, the saga, Mr. Secretary, of the contracts. You know that I've been chasing this since last March, and I requested it at a hearing, I think on March 6th, sent a letter to you, and we've all gone through various iterations. Just a few days ago, on the 22nd of January, we got a supposed new list of the canceled contracts. It turned out it was the old list. And the old list is full of obvious mistakes. It lists $79 billion worth of canceled contracts, which is more than the whole contract amount in the VA. So there's obviously something wrong with that. There are also 79 contracts listed as being canceled, which were canceled during prior administration, some as far back as 5 years. So could you please clean up this list? I just want to know what's being canceled. And this has been a saga now for almost a year. Give us a clean list of what, I don't understand why this is so complicated. What contracts have been canceled? What do they do? What are the amounts involved? And I think that's a straightforward request, but so far, it hasn't been honored.
Thanks, Senator. We'll work to alleviate your concerns and do what we can do in that. As we go forward to the contracts, and if there's a specific contract that is of concern, that is always the issue we have, but I'll make sure that you're
I just want to see a clean, realistic list without these obvious mistakes.
I understand.
And let's follow up. One more quick question about the reorganization. There were a number of parts of the structure that aren't listed in the new system: tribal health, women's health, National Chaplain Service, research oversight, readjustment counseling, human capital management, patient advocacy. They've disappeared from the organizational chart. Can you assure me that those functions are still going to be addressed in this new structure?
Yes, sir.
That's a pretty straightforward.
It's a straightforward answer for a straightforward question.
Thank you. Thank you, Mr. Chairman.
Thank you. Senator Duckworth.
Thank you, Mr. Chairman. Mr. Secretary, I'm glad that you mentioned my support for co-locating CBOCs with our VA rural hospitals. In fact, I have a bill called the Improving Access to Care for Rural Veterans Act, and it would enable VA to facilitate partnerships to co-locate CBOCs. Yet VA opposed it in December of last year in a ledge hearing. My staff has been working to try to set up a meeting with VA for technical assistance to see what we can do to get to a place where you can support this piece of legislation. Can you pin the rose on someone to help us with that?
Yes, they're listening to me now, so and I'll have Don Bergen, who is in this room, and it will happen.
Okay, thank you. Mr. Undersecretary, it's good to see you again. When we met 2 weeks ago, I requested the white paper outlining the development of the VHA reorg plan with corresponding analysis. You promised I would get it once you were confirmed. I still don't have it.
I'll follow up with the staff. I know that they had a draft last Friday, so let me see where they're at on that.
Okay, because the omission of staffing data from a 9-slide corporate pitch does not change the fact that you removed 40,000 VA employees while planning this reorganization. And if the intent is to free up resources for veterans, then resolving staffing shortages should be at the forefront of every conversation.
Senator Doug,
yes.
can I appreciate
go
your
ahead.
question because that
Go
is a
ahead.
very real concern. 40,000 jobs or 40,000 positions were not eliminated to implement RISE, and I'll be happy to let Mark Engelbaum explain that from a personnel standpoint.
Well, let's do this, Mr. Secretary.
Or I can get the information to you, whichever
Yeah, so
you
that's
prefer.
going to be
Not a
my
problem.
question. Mr. Secretary, did you, I assume that you did a detailed impact assessment that the department did, that you conducted a detailed impact assessment for this restructuring plan to mitigate risk to veterans' timely access to health care, right? You did a timely assessment as you're looking at this plan to make sure that
Actually,
that you mitigated the risks.
We are integrating right now the frontline leaders and clinicians to create those exact risk profiles. The point is, the people doing the work are the ones that best know the risk. We couldn't do that just in a small group of people. So that will be done prior to us taking any action.
So you came up with the plan before you mitigated, before you identified and mitigated the risks?
No, we evaluated appropriate structures, and then we would create a plan. You start with the current state, you look to the future state, you create an analysis of functions, you create a gap analysis, you do a risk mitigation strategy to execute on the plan. We are very much at the infancy stages of the planning. The planning has to be done by the people that are the ones that are on the receiving end of this. It's the frontline clinicians that have to drive this. They know the risk. I can't tell them what the risk is in order to implement something.
Do they have a risk assessment somewhere? Do they have a list of the risks? I mean,
the risks are being created right now.
Will you provide that to the committee?
Yes, when the risk assessments are completed as part of the overall planning process, I think that's a reasonable thing to be able to articulate.
Along with the mitigation?
Of course, we would not execute on something where we've identified a risk without a mitigation or elimination strategy.
It seems strange to me that you would come up with an entire elaborate plan without including risk. And maybe it's my Army training, but when I went to my commander, part of my decision matrix was to actually have the risk and the mitigations of the different courses of action before I asked him to choose a course of action. And you're telling me that you chose a course of action before you had fully identified the risk or come up with mitigation processes for those risks.
Senator,
it's kind of backwards.
Not really, Senator. When you look at this is not a new thing. This is not a new discussion. This is a decades-old plan. Even when you were at the VA as well, this has always been discussed. I think the issue here where there's more of a risk problem going forward, and this has been the problem at VA for years, is a risk aversion that keep us from doing exactly what we're doing right now, that we were too scared that anything would happen. The risk part here is that we were headed down a path in which we were not being able to service the veteran first. We were not being able to do the things that veterans needed because of illogical resource allocations, policies and procedures that had been let go for years that really served more of the VISN VACO structure than it did the hospitals. I believe you saw this when you were at VACO.
I did. And
we just got to get out of the VACO-centric model here back to what they're supposed to do as policy. The risk came in doing nothing. And that was the overriding from my perspective, is to go tell them after all of 2 decades of doing this, every Congress report, every OIG, every VSO, everybody else, this is why we know we need to change. And then as we move forward, we have those abilities to tweak the system to confirm that nothing is being damaged in the process and making sure that our veterans are getting the best care. And we're already starting to see good process in that.
So will you provide to this committee, to myself in particular, your list of risks to veterans' timely access to health care once those are developed and how you plan on mitigating them once it's done?
We'll take care of that as we go. We'll get you briefed on that.
Did you have a list of chosen key performance indicators and data collection methods that were implemented in developing this plan? And if you did, can you provide those to me?
Oh, we'll do that. Can I say on that? This is amazing. I appreciate you bringing that up because this was something that amazed me when I first got to the VA. Did you realize that we had no KPIs across VHA? Well, let me rephrase that. We did. We had almost 500 in which everybody just sort of did their own thing and say, I'm going to measure myself against this. One of the first things we did with the help of the folks at this table and also a guy named John Figueroa, who actually helped us look at this, we have narrowed that down to 18 KPI metrics now that every hospital in our system now uses. So everybody knows how they're getting measured, and that's one of the things that has driven the process in helping our hospitals know, here's what we do well, here's what we do not, because I can pull that up right now if I had my iPad. I could show you every hospital in our system, and they could be compared against it.
Great. Can you pull it up and hit send and send it to me tonight?
Do what now?
Can you pull it up on your
I can
iPad
pull- we
today
can-
and
we
send
can
it to
pull-
us?
We can pull data and get you those and show you
Great.
what the dashboard looks like.
Along
It's
with the-
something I didn't have. No secretary before me had this capability.
Along with the data collection methods that you're using?
We'll
Can
get
you
with
do
VHA.
that?
We'll
I mean,
get
if
with
you've got
VHA
it,
on that.
if you've got it,
Yeah.
you can pull up on your laptop.
Yeah,
Will you send
Greg,
it to us?
we can do that.
Okay. And I just want to say one final thing. Mr. Secretary, will you call on Stephen Miller and the Vice President to delete their tweet calling your employee an assassin who tried to murder federal agents?
Senator, I've already stated that my sympathies to the family in a tragic
know.
situation. I've said all I'm going to say about it.
Sure you're not going to talk to your fellow cabinet secretary and ask to the Vice President? Okay.
Senators, thank you. We had what I think is a pretty darn good hearing. We had nearly every member of the committee present and asking questions. And I think the witnesses gave good answers. They also committed to providing more information. So thank you for the good answers. Thank you for your commitment on information. If you'd like to submit a question to my colleagues, if there is a senator who'd like to submit, please do that please do that as quickly as possible. And then your witnesses will have, I should do this differently. Let's do that sentence over again. Senators who would like to submit questions or additional statements to the record for today's witnesses have 1 week to do so. So my colleagues, we have a week to ask additional questions, and I ask our witnesses to respond to those questions for the record in a very timely manner. And timely manner means in our favor, not in yours.
So, Senator, I don't have the ability to ask when you send it back. Senator, this has been good. I appreciate again, this is what we need to have in this as we look forward to it. I appreciate my colleagues. I appreciate our VHA and VA looking at what we can do for the future, and I do appreciate it. And I'll yield back.
This is one of the better hearings, in my view, that we've had with the Department of Veterans Affairs in a number of administrations. So thank you very much for that. Before I pound the gavel, I was trying to get that accomplished, but Senator Duckworth asked one too many questions. And so, Senator Blumenthal, I apparently owe you at least some time if you want to ask another question.
Thanks, Mr. Chairman. I want to just reiterate the importance of getting data from you, facility by facility, on each of these categories, on staffing. I also want the data that we have asked for repeatedly on contract cancellations. I don't know whether it's been raised while I've been out.
And Senator King and I have
Senator
had
King
a good conversation about that, ranking member. We did.
But I'd like that data. And I'd like to have a commitment that you will meet with us when we invite you to do so on a bipartisan basis.
We can definitely arrange those meetings.
Okay. Thank you, Mr. Chairman.
You're welcome. With that, the hearing is adjourned.